Hi, everyone. Why don't we get underway? I'm Steve Smith, the director of the Wiedenbaum Center and a professor of political science, and it's a great thrill to have Alan Krueger from Princeton with us today. This is our first, and we think first of many, many Murray Wiedenbaum Memorial Lectures. Many of you knew Murray, but some of you have only heard the name. So let me just say a word about the importance of Murray to Washington University and to the world of public policy and economics. Murray got his PhD in economics from Princeton back in the 50s and became a professor of economics at WashU in 1964. Murray passed away in 2014 during a semester in which he was still teaching here at the university. He never retired, so he put in, count them, 50 years as a professor of economics. Murray specialized in public finance, had a great interest in regulation, the regulation of business, was a strong advocate of free trade, and took an interest, a special interest in defense policy. He worked actually in the defense industry as a young economist. And along the way, managed to serve as Assistant Secretary of the Treasury for Economic Policy. That was in the Nixon administration, created what became later the Wiedenbaum Center when he returned to campus in the mid-1970s. Then went back to Washington to serve as President Reagan's first chairman of the Council of Economic Advisors in 81 and 82, and served on a variety of commissions, too numerous to recount here, over the course of all of those decades, serving both as a scholar and as a public servant. Quite a remarkable record, and a very important teacher. In his last couple of decades on campus, he and Tom Eagleton, the former somewhat liberal Democrat from Missouri, team taught a course on government and business, the Tom and Murray Show. Sometimes it was called Eaglebaum for short. That was extremely popular, and after Senator Eagleton passed away, Murray continued the course for many years. So it's a thrill to have a lecture series named after Murray. It's a double thrill because we have with us today Alan Krueger from Princeton. Alan is the Bentheim Professor of Economics and Public Affairs at Princeton. He's simply one of the world's leading labor and microeconomists. He's published widely on a remarkable range of policy problems, the economics of education, the environment, unemployment, labor demand, income distribution, social insurance. Many of us know him because of his work on the minimum wage. A great book on the economics of terrorism, and on top of that, he has managed to be Assistant Secretary of the Treasury for Economic Policy, Chairman of the President's Council on Chairman of the Council of Economic Advisors, a little bit like Murray. His politics are a little different. He worked in the Obama administration. I don't think Murray would have. But like Murray, I think he's an economist first and a politician second. Professor Krueger served in the Obama administration as chair of the CEA in 2011 through 13. Before all of that, he was the chief economist at the U.S. Department of Labor. On top of all that, he served as vice president of the American Economics Association. So if anyone embodies Murray's record of scholarship and public service, it's Professor Krueger. He serves on the board of directors at BNP Paribas, been on the board of directors at Russell Sage and MacArthur Foundations. And of course, before all of that, he got his PhD in economics from Harvard. It's a great thrill to have Professor Krueger here to talk about yet another application of economic analysis to one more important problem, the opioid crisis. Please join me in welcoming Professor Krueger to WashU.
Thanks very much, Steve. Thank you very much, Steve, for that very generous introduction, and thanks for coming outside in the snowstorm this afternoon. It seems appropriate to say a few words about Murray Wiedenbaum to start with, and it's a real honor for me to give the inaugural Wiedenbaum Lecture. I met Murray Wiedenbaum in 1992, and we were on a panel together, and we debated benefit-cost analysis in regulation. At the time, it seemed to me that Murray's presentation only focused on the costs of regulation. He might say I focused only on the benefits of regulation. And we have very much had parallel careers. As Steve mentioned, we both served in the same capacity as Assistant Secretary of the Treasury, which is a great job, one of the most underappreciated and important jobs with a great office overlooking the White House, and then as Chairman of the Council of Economic Advisors on the other side of the White House, also with a good view. When President Obama nominated me to be chairman, Murray sent me a copy of a short book that he wrote, which were essentially his memoirs from the time when he was chairman of Reagan's Council of Economic Advisors. And Steve knows this, there's a little bit of time when you're waiting to be confirmed where you can't do too much. You can't talk to the press. You kind of just hope for the best. So I read Murray's book very closely, and I learned one very important thing in it. It mentioned that the council was set up as 3 members, one of whom was appointed by the president to be chairman. And initially it was a disaster because the members all thought they had an equal voice and equal power. And Murray pointed out that the council was reorganized, and the chairman was vested with the authority to speak for the council and control of the budget, which I had to occasionally remind the other members about. As Steve mentioned, we probably have different politics, but I think there was a lot of mutual respect between Murray Wiedenbaum and myself. And I think that's been true of, I would say, all of the previous chairmen of the CEA who I've met. I want to talk today about a critical issue. I call this Economics in the Opioid Crisis because I couldn't think of a better title. I'm going to talk more about the opioid crisis from the perspective of an economist, and I'll try to touch on much of the research that's been done by economists to try to understand the opioid crisis. The outline for my remarks is I'll begin by talking about work by my colleagues Ann Case and Angus Deaton, which is the first work in economics that drew my attention to the opioid crisis. They called it Deaths of Despair, on how the drug epidemic in the U.S. and the opioid crisis in particular is affecting life expectancy, mortality rates. Then I'll discuss causes of the epidemic, my research on how the spread of opioid medication has been affecting labor force participation. I'll talk about one of the best, maybe the best study the current Economic Advisors has conducted on the opioid crisis, where they come up with, I think, a credible estimate of the tremendous costs of the crisis, which are actually even much larger than they were 2 years ago. And then I'll conclude by saying a little bit about policy options. So I first discovered or came across this issue from a paper that Ann Case and Angus Deaton presented. And then about 6 months later, Angus Deaton won the Nobel Prize, so the work got a huge amount of attention. I've discovered it's helpful for a Nobel Prize winner to have work that is timely at the time of winning the prize, and understandable because I think Case and Deaton had a huge impact with their work. This was the first figure that was in their study. This shows the mortality rate for 50 to 54-year-olds. I just chose that age group. And you would see a similar picture if you looked at 40-year-olds or 60-year-olds. The red line is the all-cause mortality rate for those who have a high school degree or less. You can see that that has been rising since 2000. The blue line on top are for black and non-Hispanics. This line is for all whites and non-Hispanics. And the blue line at the bottom is Hispanics. So what jumps out at you here, of course, is that the mortality rate has been edging up for whites with less than a high school degree in middle age, and rose rather sharply after 2010. This group is an outlier across the world. In red, again, it's white non-Hispanics. These other lines show the mortality rate over time. This is for a slightly broader age range, 45 to 54, but the same general pattern. The other lines are other countries: France, Germany, the UK, Canada, Australia, Sweden. So the U.S. is a real outlier. What's driving this? Why does the U.S. have such a disappointing trend when it comes to mortality? What Case and Deaton discovered is that there's been a tremendous rise in what the CDC calls deaths due to drug, alcohol, suicide. And that's particularly the case for U.S. whites. The trends look different in most other countries. Now, there's a little bit of good news in their study. Mortality rates from other causes are declining. The left shows you mortality rate from heart disease. The U.S. is in red. That's declining. The right shows you mortality from cancer. That's also declining. So I don't want you to leave terribly depressed. But we do have a serious problem when it comes to drug and alcohol overdoses. This chart was produced about a month ago. The 2017 data are still preliminary. They call them provisional. This is from the Center for Disease Control. And the bars show you the number of Americans who are dying from drug overdoses each year. In 2017, that was 72,000. That works out to just about 200 people per day. The red line is men, and the mustard colored line is women. And you can see that the number is higher for men than it is for women. About 70% of the 72,000 drug overdoses are related to opioid use. So let me switch and talk specifically about the opioid crisis. This is the latest data from the CDC on the number of Americans dying from opioid-related drug use. The best estimate for 2017 that they have is 49,000. That's probably an underestimate. Research by the economist Chris Room has found that the death certificates often underreport opioid utilization. His estimate is the official statistics probably understate the opioid-related overdoses by about a quarter, about 25%. So if that number held in 2017, it would be 167 deaths per day as a result of opioid overdoses. Now, these are statistics which paint a very disturbing picture, and I don't want to lose sight of the human element. There was an article that was written by Admiral Sandy Winnefeld, who I worked with. His nickname is Sandy. His name is James. He was the vice chairman of the Joint Chiefs of Staff from 2011 to 2015, I believe. And this article was published in the Atlantic magazine about a year ago. And when it came out, I read this, and I assigned it to my students at Princeton. He and his wife took their son, Jonathan, to college. Their son struggled with addiction his whole life, depression, anxiety as well. If a family had done anything to help their son, this was the family. They tried mightily to help Jonathan overcome his addiction. He went to a residential treatment program for about 16 months. He thought he had solved the problem, thought that he had purpose in his life. He received certification as an emergency medical technician. That was his goal. They dropped him off at school. This is the last photograph that he appeared in. 3 days later, he had overdosed from fentanyl and heroin. And the article that Admiral Winnefeld wrote was really striking to me because, number one, to be composed to write a thoughtful article at that time. The article, and I encourage you to read it, the article describes their son Jonathan and the struggles that he faced. Also discusses policy options, which I'll come back to at the end. I thought I'd read you a little bit about what Admiral Winnefeld wrote. On the surface, Jonathan was a handsome, shy, gentle kid with a warm and disarming demeanor. But underneath that exterior, he struggled with anxiety and depression, which spiraled into addiction with all its sickening complexity. He titled the article, "No Family is Safe from This Epidemic." And he concluded the article by saying, "Losing Jonathan has left us heartbroken, but we are determined to carry on his purpose. If his story leads to one less heartbroken family, it will have been worth sharing." So I don't want to lose touch of the human element. This is an economic tragedy, and it is a human tragedy for far too many American families. With that, I'll return to sharing some more statistics on the dimensions of the crisis. This chart shows you the total number of fatal overdoses each year. So this is a similar number, same number I showed you before, 72,000 overdoses last year. These other lines show you the drugs that were associated with the overdoses. And you see this sharp increase in overdoses from fentanyl. Pain medication, this is opioid pain medication. I've simplified their categories a bit. Opioid pain medication is kind of hopefully plateauing. Heroin has been rising. And that's what contributes to the 49,000 opioid-related fatalities. Almost 30,000, just shy of 30,000 overdoses from fentanyl last year. These are not totally mutually exclusive categories. How does Missouri look? Well, Missouri is a little bit above average. The purple states are the groups with the highest number of drug overdoses per capita. I think this may also be age-adjusted, adjusted for the age. It doesn't really matter all that much, but adjusted for the age of the population in the state. Missouri is on the high end, but not off the charts. I put together this chart showing opioid-related overdoses, Missouri versus the U.S. This is for everyone age 15 and over. I didn't adjust for population here. So you can see that the rate has been growing in Missouri a little bit faster than in the U.S., and is a little bit above the U.S. average. This shows you some other states, West Virginia, which is off the charts, Ohio, Kentucky. This is from the Council of Economic Advisors report. They looked at the age of those who were dying from opioid-related overdoses, and you can see that they're disproportionately prime working age 25 to 55. Okay, what are the causes of this epidemic? At a general level, I think there was a recognition that pain is a debilitating problem for a great many Americans. And I don't want to minimize the impact of pain on people's lives. At the same time, I think pharmaceutical companies marketed their opioid medications as safer than they were. This led doctors to greatly overprescribe opioid-related medication. I wanted to briefly describe a study that my colleague Janet Curry and a Princeton PhD student, Molly Schnell, wrote, which has a remarkable result. They looked at opioid prescription rates based on doctors' backgrounds. And what they found was that doctors who went to lower-ranked medical schools prescribed significantly more opioid medication. So comparing doctors from the top-ranked medical schools like Washington University or Harvard versus those at the bottom, there was an enormous difference in opioid prescription rates, which couldn't be accounted for by the type of practice the doctors had, by the location of the doctors, which suggests that there's something amiss in our medical training. This is on the supply side. I don't want to minimize the demand side. Case and Deaton argue that these are examples of deaths of despair. They argue that economic anxiety has helped to propel the opioid crisis, that individuals who were facing diminished economic expectations were more vulnerable to taking opioid medication and more likely to become addicted. There probably also has been a role of insurance companies in the spread of the epidemic. Compared to other pain medications that are more expensive, insurance companies have often been more willing to reimburse for opioid medication. And you can look and see, if you think back about that chart I showed you a moment ago, different waves of the crisis. It looks like it began with prescription medication, and many people became addicted because of prescription medication. Then it seems that many people looked for alternatives, maybe cheaper alternatives, or maybe the doctors stopped prescribing to them. Then you see a wave related to heroin, and most recently, a wave related to fentanyl. Prescription pain medication, prescription opioid pain medication increased by almost 400% between 1999 and 2015. The good news is the medical profession seems to understand that this is a tremendous crisis, and prescriptions have been coming down since 2013. So if the original source of the problem was over-prescribing of opioid pain medication, that problem looks like it has peaked, even though the U.S. still has extremely high prescription rates compared to the rest of the world. Those rates are declining. So it's possible that the initial source of the problem is beginning to wane, which is certainly positive, but we will be facing the effects of the large prescription rates, the excessive prescription rates, in my view, for years to come. Let me next talk about the economic implications of this public health crisis. I approached this by work I had done on labor force participation, and in particular trying to understand why labor force participation of men has been declining in the U.S. and is low compared to many other countries. I call this the Kramer effect, or the Kramer lifestyle. If you watch Seinfeld, you can never figure out what Kramer does. He doesn't work. He's not looking for a job. He's out of the labor force. How does he support himself? And it's, frankly, a mystery among economists how so many prime, not Kramer per se, but the phenomenon, why there's so many prime working age men who are out of the labor force and how are they supporting themselves. So that's the question that originally motivated me. And I was invited to give a presentation by the Federal Reserve Bank of Boston on this issue. And I looked at a whole bunch of explanations, and then I started to look at health-related issues, and that led me to look at the opioid crisis. So I'll give you a little bit of background on trends in labor force participation, and then say more about the opioid crisis. Just for your background, labor force is extremely important for the U.S. because you can think of economic activity as depending upon productivity, amount of output we have per worker, and the number of workers we have. And if labor force is stagnant or growing more slowly, which it is because of our demographics, then that's going to be a constraint on economic growth going forward. And those constraints, I think, are beginning to bind for the U.S. economy. So this shows you the labor force participation rate of men and women. And just to be perfectly clear, this is defined as the number of, if you take the blue line on top, men, the number of men who are employed or unemployed but looking for a job relative to the population of men. Both the numerator and the denominator are those aged 25 to 54. So you can think of this as the proportion of men who are in the workforce. And on this scale, it's a little bit hard to see, but the blue line, the labor force participation rate for men, has been edging down from a high of around 96%, 97%, down to 88%. And then started to rebound just a little bit over the last few years as the economy got even stronger. So right now, about 11% of men aged 25 to 54 are not working and not looking for a job. U.S. labor force participation rate rose pretty steadily in the post-war period. What drove that rise was women. After World War II, more and more women joined the labor force. But that came to an end around 2001. And labor force participation of women actually declined in the last recovery. Before the Great Recession, labor force participation rate of women had started to decline, and then it continued to decline, although it started to recover a little bit in the recovery. So we lost the engine that was driving labor force participation in the U.S. If you look at men broken down by their education level, this trend is most severe for those who have lower level of education, high school or less. About 17% of men with a high school degree or less are not part of the labor force. These lines are all sloping downward. So even for men with a bachelor's degree or higher, we've seen a decline in labor force participation. But the fact that the decline was so much sharper for the less educated suggests that this is related to economic forces. And opportunities for those with less education have diminished in the U.S. over the last 20 years, over the last 30 years. That's generally considered the main driving force here, that wages have declined or stagnated for less educated men. Demand for their services have declined. That's why we've seen a sharper drop in labor force participation for less educated men. And that may well be why, as Case and Deaton argue, we see an increase, particularly for less educated men, in terms of alcohol poisoning and drug overdoses. I use data from the American Time Use Survey, which asks people about how they spend their time. And I had added a supplement to the survey together with my colleague Danny Kahneman, where we asked people about how they felt about their activities. We also asked whether they felt pain during their daily activities. And we asked whether they took pain medication. And some of these results are really shocking. So this top panel shows you men from the Bureau of Labor Statistics survey, the American Time Use survey. And people are asked to rate their health. Is it excellent, very good, good, fair, or poor? And this is looking at men aged 25 to 54 at top, women aged 25 to 54 on the bottom. If you look at the men who are out of the labor force, 43% of them say that their health is poor or fair. For men who are employed versus unemployed, it's about the same. Much lower, about 13, 14%. say that their health is poor or fair. So the men who are out of the labor force, a large number of them perceive that they have health problems. This is less the case for women. If you look at women who are out of the labor force, 31% say that their health is poor or fair. It looks like there's a more severe health problem for the men who are out of the labor force. I discovered a little bit too late there were really two groups of women who are out of the labor force. One group is taking care of family. They look healthy. They look as healthy as employees. And they also look quite content with their life. There's another group which is out of the labor force for other reasons, and they have reported health which is at least as bad as the men's. I'll show you a little bit more on this later. And they're also more likely to take pain medication and to report that they feel pain. And those two groups of women are about the same size, so I'll say a little bit more about that later on. The reason why I focus on men is because the group of men who are out of the labor force report worse health than do the women. The survey asked men about specific disabilities. Do they have difficulty dressing or bathing? Are they deaf or have severe difficulty hearing? Are they blind or have severe difficulty seeing? And some of these numbers are really eye-opening. If you look at men who are out of the labor force, 20% say they have difficulty walking or climbing stairs. These are aged 25 to 54. 17% say they have difficulty concentrating, remembering, or making decisions. Just over a third report one of these severe functional disabilities. 19% report more than one. This survey asked people about whether they felt pain. I calculated the percent of their day in which they said that they had the presence of some pain. For those men aged 25 to 54 out of the labor force, 52% of the day on average, they reported feeling some pain. And this number really kind of caught my attention. 43.5% said that they had taken pain medication on the previous day. Now, the way the question was phrased, and I'm responsible for phrasing it, is, yesterday, did you take pain medication such as an aspirin, Advil, or prescription medication? One would think differently about this if it's an aspirin versus taking prescription medication. So to try to find out, I conducted my own survey where I asked them. Actually, before I did that, I had some other results I wanted to show you. If you look at that group of less educated men, and especially white men with less than a bachelor's degree, 50% said they took pain medication on the preceding day. This compares, Bloomberg is much better at making charts than me. So I'll show you this chart from Bloomberg. This is the number I just showed you. 43.5% of the men out of the labor force said that they took pain medication on the preceding day. 34.7% of women. So the women look like they are not turning to pain medication as much. But if you look at employed women, or women overall, women are actually more likely to take pain medication. And I think this is, again, because there are two groups of women who are out of the labor force. The group that's primarily taking care of children look very healthy and they look very content, and they're much less likely to take pain medication than the other group of women. So to try to learn what it is that people are taking, what type of pain medication, I conducted a survey of 571 men who were out of the labor force. I did this 2 years ago, end of September, beginning of October of 2016. And the results were so interesting, I decided to go back to them a second time. So about 9 months later, in July of 2017, I re-interviewed them. And I'll share the results of this study with you. You need to sample a large group to find 25 to 50-year-old men who are out of the labor force. It's 11, 12% of the population of men aged 25 to 54. So you have to screen out quite a few to find 570 who qualify for the survey. 47% of the men in my sample said they took pain medication on the preceding day. Very close to what the Bureau of Labor Statistics found. And the fact that my data are actually more recent makes me think that the numbers probably increased, comparing the 43.5% to 47%. Most importantly, 65% of those who took pain medication reported that they took prescription medication. Many said they took both prescription and over-the-counter medication. So about 2/3 of the 44% of men who are taking pain medication look like they're taking prescription medication. Now, I didn't ask whether it was opioid-related because they might not know. They might know it's OxyContin, but they might not know what's in it. But most likely, a large number are taking opioid medication. What else did I find? In my sample, 2/3 reported a disability. Now, I used the categories that the Bureau of Labor Statistics had, and I also gave them a chance to write in other. 16% listed another type of disability. So the BLS's list, I think, was a little bit narrow. And it's also possible that the group in my internet survey is more likely to have a disability than the group of men in general. 35% reported that they received Social Security disability insurance. This gets at the Kramer puzzle a little bit. 35% seems about right compared to administrative data, maybe a little bit on the high end. But a significant number of those who are not receiving disability insurance are actually applying for disability insurance. And what I found in the follow-up survey, if you add those in, about half of the men who are out of the labor force, working age, 25 to 54, are either receiving disability insurance or in the process of applying for disability insurance or have been recently rejected for disability insurance. This isn't surprising given how addictive opioid medication is. There was high persistence from one wave of the survey to the next in taking prescription pain medication. How are they paying for their pain medication? Mostly through government programs. 38% said Medicaid, 29% said Medicare, 10% said a VA program. Now, that also suggests that there may be more levers to try to control the prescription of pain medication, since so much of it is going through government-related health programs for those men who are out of the labor force. I asked, what was the source of pain that led you to take pain medication? Only 12% said it was work-related. So if the picture you have in your mind is somebody got injured working on a physical job, that's a small number of cases, just 12%. And it's not so shocking. In the U.S., work injuries have been declining as we've transitioned from an industrial to a service economy, and also even within industries, work has become safer. So most of the sources of pain are outside of work. We've seen this tremendous increase in opioid prescriptions. I mentioned before almost a 400% increase in prescription of opioid medication since 1999. We don't see any sign that pain has declined. Granted, we don't have great data asking people about their experience with pain, but there are large surveys conducted by the National Health Interview Survey which ask people about whether they've had specific types of pain, like back pain, neck pain, leg pain, jaw pain, severe headache, over the last 3 months. And I disaggregated the data by employment status. The purple lines on top are not in the labor force. And it doesn't certainly look to my eye like pain is declining. And if you fit a trend, there's slightly upward trend in the proportion of people who report that they felt pain over the last 3 months. And again, this is a result for 25 to 54-year-olds. If you look at other subsamples of the population, you reach a similar conclusion. This is not inconsistent with the medical literature. The medical literature finds very little evidence that opioid medication reduces chronic pain in the long run. It may have short-run effects, but very little evidence that it has a positive effect in the long run. So let me get back to women a little bit. here I divide the sample into women who are out of the labor force, and they say the reason that they're not looking for a job and not working is because they're taking care of home responsibilities. The other group is everybody else. Those two groups are almost equal size. And you can see, if you look at the everybody else group, 49.4% took pain medication on the preceding day. If you look at other indicators, based on the American Time Use Survey, people reported their satisfaction with their life, for example. This group of women looks very much like the group of prime working age men who are out of the labor force. They look very dissatisfied with their lives. The other women look quite content with their lives. They have purpose in their life. That's another question that we asked. This shows you men who are out of the labor force. So this is just another way of carving the data I showed you before. The fraction of prime working age men who are not in the labor force each year from 1991 to 2015, that's what's increased from 6% up to 11%. The red line are women who are out of the labor force, also aged 25 to 54, and they're not taking care of home responsibilities. That's not what they list as their reason. And you can see they're almost the same lines. So I think we focused a lot on the problem of men who are out of the labor force, but there's an equally important problem of women who are out of the labor force. It's just a bit masked by the fact that about half of the women who are out of the labor force and age 25 to 54 are mainly taking care of family responsibilities. So let me try to connect this with the opioid crisis. And what I have said on many occasions is that our problem of low labor force participation, declining labor force participation, has run into the opioid crisis. This map shows you the prescription rate of opioids per capita across counties in the U.S. Areas that are white, we don't have data. The darker red, the prescription rate is much higher. And this is measured by morphine milligram equivalents. So you can think of this as sort of being equivalent capsules being prescribed. And this is just medication that's being prescribed, not illegal medication. So what do you see here? Well, you see very strong regional patterns. Very high prescription rates in northern Michigan, through Appalachia, up in Maine and New Hampshire, western Nevada. It's a bit hard to look at that and say, this looks just like the Rust Belt. It's sort of a Rorschach test. But the pattern, to me, looks like it's much more complicated. And to me, that's consistent with the process I described earlier of pharmaceutical companies marketing the medication in certain areas, doctors, particularly those who went to less prestigious medical schools and might be less adept at addressing problems apart from prescribing medication, and perhaps a demand in parts of the country on the behalf of the public for opioid-related medication. The differences are enormous. If you rank all the counties by the prescription rate and compare the average of the top 10% of counties versus the average of the bottom 10% of counties, the difference is 31 to 1. Those differences are enormous. And I tried to say, can we account? I had no illusion that you were going to read this table. But it's just there to show you that I did this careful analysis. What I did was to say, how much of people's behavior taking pain medication is related to the amount that's being prescribed in the area where they live? How much is a function of their own physical health? They report their subjective health rating, they report their physical disabilities, and you cannot account for very much. You can account for some of the regional patterns, but at most half of the regional patterns. that suggests that the same person living in different parts of the U.S. is more likely to be prescribed opioid-related pain medication if they live in an area where doctors prescribe more medication. Differences in the characteristics of people across counties, differences in their physical health, can't explain those wide differences that I highlighted in the map. So what I do next is I compare the opioid prescription rate to the decline in labor force participation. The decline in labor force participation is not uniform across the country. So what I do here, and it's not so easy to do, is I try to highlight areas in green where we have high opioid prescription rate and a big decline in labor force participation versus areas in light green where either there's low opioid prescription rate or a small change in labor force participation. And then in between. So you see a lot of areas of dark green and a lot of areas where it's not shaded in. What that's telling us is we have a spatial correlation between the opioid prescription rate and the decline in the labor force participation rate. And that's what this next regression table tells you. And when I originally published this, I was embarrassed to discover I made a mistake, and the effect is actually bigger than I thought. So I originally published this work in the Brookings papers, and I calculated that the nearly fourfold increase in labor force participation accounted for about a 20% decline in the male labor force participation rate. Then I realized that I mixed up my bases for the logarithm. Embarrassing mistake, but I'll tell you in case there are students here, so I don't want you to make the same mistake. Excel uses log base 10, and Stata uses the natural log. So I made kind of a freshman mistake, and it's better to get things right in the end. So when you do the calculation correctly, it's 40%, not 20%. So that suggests that the spread of opioid medication has been a major contributor to the decline in labor force participation for men, reaching an even stronger conclusion for women. This leaves unanswered the question, what is causing what? Is it the spread of opioid medication that accelerated the decline in labor force participation over the last 2 decades? Or is it the lack of opportunity, the decline in demand, the stagnation in earnings opportunities, particularly for less educated men, that led them to seek ways to escape, such as through opioid medication? I suspect the arrows go in both directions. I've done some analysis where I tried to use variability in the regional prescription rate based on the Medicare program. So I could calculate for those 65 and over who are on Medicare what fraction were receiving opioid prescriptions from doctors in each county. And I could use that as a way of shifting the prescription rate for prime working age individuals. And when I do that, I get an even larger impact. That suggests that it's medical practices that are driving the decline in labor force participation rather than economic conditions driving people to seek out opioid medication. It's still a tentative conclusion. As I said before, I suspect that the arrows point in both directions. And regardless, it's a problem in that a significant share of prime working age individuals who are out of the labor force are taking pain medication regularly. That makes, I think, obtaining a full-time job even more difficult for those individuals. Let me say a little bit about the CEA report. The Council of Economic Advisors a year ago released a report where they tried to derive an overall estimate of the economic impact of the opioid crisis on the U.S. economy. And I think they did a service in their work. Rather than focus just on labor force or just on lost productivity, they tried to generate the whole picture. And I think they're absolutely right in recognizing that the number one cost from the crisis is the loss of life that we've experienced. and it's even worse than when they produced their report. They had numbers through 2015. And the approach they used is the same approach that economists have used for a long time to try to estimate the statistical value of a life, to try to put a number on the cost of the lives that we've lost because of the crisis. How did they do that? Well, the idea goes back to Adam Smith in 1776. Adam Smith pointed out that coal workers got paid a higher wage because their job was risky, because they faced an elevated risk of dying on the job, also was hard work. And there's a big literature which tries to say, given the different risks on different jobs, how much extra compensation do people need to be offered in order to take those jobs? And you can extrapolate from those numbers, and the estimates are around $10 million for a statistical life. Now, this is a term which may sound a bit coarse to non-economists. I think there are a number of extreme assumptions that go into coming up with an estimate like this, and it's probably an underestimate. We're looking at risk of work-related fatality of 0.001% on some jobs and as high as 2% on other jobs. And then we're extrapolating to 100%. So we're extrapolating way beyond the range of our data. There's no reason to think that we should be able to extrapolate linearly. I would think it's probably nonlinear. The people who are less risk-averse are likely to sort into jobs which have a lower risk. Those who are more risk-averse, less risk-averse would sort into a job with higher risk. Yet we want to apply this job, this compensating differential to everyone. We're assuming that people are knowledgeable about the risks that they face, which is an open question. So there are a lot of caveats to this kind of a calculation. On the other hand, the U.S. government, going back to Murray Wiedenbaum's day at the Council of Economic Advisors, has required benefit cost analysis for all new regulations. And for many regulations where the safety of the public is at risk, goes through a calculation like this. And at least it's using a consistent mechanism so that we can try to allocate our resources where we can have the greatest impact in reducing risk. So what did the Council of Economic Advisors find? Their preferred estimate was the loss of human life from the opioid crisis is costing the U.S. economy about $430 billion a year. Now, that's only part of the cost. The rest of the cost brings it up to about $500 billion. Loss in labor force, loss in productivity, treatment. $500 billion is the economic cost that the Council of Economic Advisors came up with for the opioid crisis. The problem has gotten 50% worse since then. When they looked, there were 33,000 fatalities from opioid usage. Today it looks like 50,000. So the number today is, I would estimate, in excess of $750 billion a year. So that's an enormous loss to the U.S. economy. And let me conclude by saying a little bit about public policy. I think President Trump was right to highlight the opioid crisis during the campaign. I would like to see him follow up with much more action. The president assembled a commission which was chaired by my high school classmate, Chris Christie. He doesn't look like it there, but he was an excellent baseball player in high school. And the President's Commission came up, I think, with a bunch of sensible recommendations. The problem is that Congress has done very little to fund them. Congress has increased funding for the opioid crisis, but compared to the scale of the problem, it's not even keeping up with the increase in the scale of the problem. So President Trump declared the opioid crisis a public health emergency. That gave him a little bit of additional authority to speed up some research which is taking place. The commission recommended An obvious solution: limit the number of pills that doctors can prescribe. To get additional medication, you need to come in for another checkup, for another prescription. Now, there have been some very notable cases recently of doctors abusing this system and prescribing enormous amounts, but I suspect most doctors want to treat their patients appropriately. And one of the problems is that if people get an initial prescription of 30 pills or 60 pills, that's far more than they often need, and it makes it too easy for them to continue taking medication and to become addicted. Look for alternative treatments for pain. This is an area where I think there's an urgent need to invest more of our research resources into finding alternative therapies for dealing with pain, especially because opioid medication doesn't seem very effective for most chronic problems. More drug courts, treating addiction as a mental health problem. More treatment slots for those who are addicted. Only about 1 in 5 of those who are addicted to opioid medication ever go through therapy for addiction. Better emergency room treatment for those who are overdosing. The Philippines approach, I fear that this is the one that appeals most to the president, to the exclusion of the others, which is to be very, very tough on drug dealers. Portugal approach, to have controlled markets which dispense methadone that have trained professionals available. And the evidence suggests that they've been very effective. Interestingly, if you read Admiral Winnefeld's piece in The Atlantic, he's just searching for a solution. He talks about being tough with the drug dealers and notes that he hopes that they find the person who sold his son the fatal overdose and prosecute him. He also talks about the potential for open markets where there's a controlled allocation of methadone and treatment available. Another track that's been taking place independent of the commission is lawsuits against the pharmaceutical companies. And I get called about monthly about these cases, and the liability is extremely high for the pharmaceutical companies, and I suspect, like the tobacco lawsuits, these will go on for a while, and hopefully will discourage the pharmaceutical companies from falsely marketing medication. And I want to end on a somewhat ominous note, which is, while we've been focused on the opioid crisis, other drug epidemics have started and have been spreading. And I think we need to be very careful to be vigilant and to ensure that we address these problems as they arise and not let it develop to the stage that the opioid crisis has developed. This is the same chart I showed you earlier with fentanyl. I mean, you just see the number of overdoses from fentanyl. I misspelled it, but you see the blue line, shooting up to the ceiling. But look at methamphetamine and cocaine, and combined, over 25,000 fatalities in 2017. When I talk to the companies that do drug testing of employees, they have told me that they're detecting less opioid in people's system and much more methamphetamine. So my worry is that while we focus on treating one very important component of the drug epidemic, others are going to open up. And I think that leads me to emphasize the importance of addressing mental health problems, which I think are at the root of many of these problems. So why don't I stop there? I hope I've left time for questions. Once again, I'm honored to have been invited to present the first Marie Wiedenbaum lecture.
Thank you for that interesting presentation. I appreciate your attention to the link between the epidemic and economic issues and the role that doctors can play in overcoming. But I was curious about the racial aspect. but I'm not clear from your presentation exactly why this opioid crisis is pronounced among white male populations in particular, especially given that these sorts of economic issues and disinvestment have been present in minority communities for several decades. And I also wonder if you could comment on whether or not you think that might be a factor in why there's been such a shift in tone in the role of addressing this epidemic in ways that were not present if we went back to the 1990s or the 1990s.
Right. It's a great question. The epidemic is much worse among whites, especially less educated whites. That's why I focused on less educated whites. To the extent I did, much of what I showed was looking at violence and across all groups. Why is it less prevalent? That's a fascinating question. I think some of it has to do with I think as an economist, so both the supply side and the demand side of the market. On the part of patients, I think African Americans are more skeptical of medical treatments. And I think there's also evidence, although I'm not an expert in the medical literature, that doctors, when they hear a patient complaining about pain, are more skeptical when it comes from a racial minority than it comes from someone who's white. So they may well be less likely to prescribe opioid medication as well. So in that case, it's been a fortunate combination. Now, doesn't mean that it's kind of we're in an optimal situation. And in fact, the differential reaction that you mentioned earlier to the crack cocaine epidemic and the opioid epidemic is, I think, a very valid point. I think we need to treat addiction as a mental health problem. And what I was struck by as I read the piece by Admiral Winterfeld, it was beautifully written. I don't know how he was able to write it, actually. A couple of weeks after, less than a month after his son overdosed. And he said that, many people have this simple understanding of addiction. And he explained, better than I'd seen for a general audience, the connection between mental health problems and addiction. I think we need to treat many of these problems as mental health problems. And that's why I worry about the Philippine solution, which just can exacerbate the problem, to be honest. Those are my thoughts. But I'm not the greatest expert on some of those issues. I saw you back there.
So this is a bit two-part. I'll try and make it short. So one is that, so you mentioned that there seems to be this relationship between medical practices and the rate of opioid overdose because they're more likely to prescribe and so forth. But you mentioned how it varies depending on their education, the prestige of the medical school they attended. My question is, have you considered maybe that what's going on is not necessarily just the prestige, but also the income earning potential of those doctors, and how it varies across the country, particularly I would guess in rural areas, and how it's whether it's in the Medicaid and various less profit making insurance avenues. But anyway, so what I'm trying to say is it possible that what's really going on is you get doctors who know make a lot of money, who see this as the only cheap way to give it to people who are already at low earning potential, who are out of the job. So because of their low earning potential in the areas that they're in, you're going to see a situation where because they're unemployed, this is the best option for them, and that's what's driving this problem instead of maybe just the medical practices, exacerbating economic depravity. So, that's one way. I'll just leave it at that because that was long enough.
Right. That's certainly plausible. It doesn't seem to fit with the fact that when we look within the same geographic area, the doctors who have been trained at more prestigious medical schools prescribe less. Even if you look at the same specialties, they prescribe less. Now, I do think about the doctor's incentives, and as an economist, it's malpractice if I don't. One of the things I suspect is the case is that for a doctor who is pressed for time, writing a prescription is a pretty easy way to address complaints or the issues that they have before them. And I don't know if that accounts for much of the differences across the country, or much of the growth in the prescribing rate. And there are some experiments that have been done to provide information to doctors about the outcomes for their patients, which we don't do enough of. And if doctors discover or are informed that a patient had overdosed, they subsequently prescribe less. So some of it, I think, is just doctors learning more. And the last thing I'll say about this is, more recently, the effect of the medical school that the doctor attended is less important, which suggests that the training is becoming more uniform across medical schools. Yes, sir?
Several things. You didn't discuss about the drugs coming over the border and the drug cartels, which eventually come through all of our cities here, and where all these murders in St. Louis, a lot of them are all drug-related. Mostly illegal drugs, not the ones that are prescribed. The difference in the medical schools here, Washington U turns out a class of about 100 to 125. Most of those, a lot of those people go into research and into specialties where they're not really seeing the general public. Where you take a school, the Kansas City College of Medicine and Bioscience in Kansas City, has a class of 500 people, and 75% of those go into general practice. Those are the ones that are seeing the people, whereas the people that are graduating in Washington U are not seeing the general people in the population. They're on a much higher level. That's the difference there. The other thing is medical marijuana, which has been just come into legalized medical marijuana in Missouri. You go to Colorado where they have recreational marijuana. There are a number of just car accidents that's being skyrocketing now because of people smoking and driving around. That has a huge economic factor, which is going to really jump throughout the United States because medical marijuana here is just the first step in getting recreational marijuana. That's what they really want. That's where the money's at. So you have to put all of these things in and figure that into the economics of how this is going to be the future. Because I don't think it's so much of a prescription. I think it's the drug cartels. I think it's the medical marijuana, where they start with medical marijuana, and they start with marijuana. That's just the first step into getting into higher drugs.
So there's an awful lot there. Let me just say a few things really fun.
Can you repeat the question?
I'll do my best. Some of the fentanyl is coming in illegal, there's no question, and some of it being produced domestically. And I think it's going to be a game of whack-a-mole, because if we do a better job interdicting it at the border, it'll be produced more domestically. But what you said is correct. Nonetheless, the crisis began with prescription medication, and that's what led people to be seeking cheaper alternatives and stronger alternatives. And that's something which the medical community can address. Certainly doctors from top-ranked schools do treat patients. Even I have a good friend, one of my closest friends, went to Washington University and is now at UCSF Medical School. But he sees he does rounds, he sees a lot of patients. So the doctors from the top schools and middle-ranked schools compared to the bottom-ranked schools, we see a difference in the prescription rates. Yes?
Do you have an opinion about whether or not the Joint Commission on Hospital Accreditation is requiring hospital patients to rate their case from 1 to 10?
I didn't hear 6, say it again. Requiring?
The KCHA, the Joint Commission on Hospital Accreditation, required hospitals to have patients rate their pain from 1 to 10 because they were saying that doctors weren't giving enough medications to control pain.
Right.
It just seems to be that was the start of this.
That's entirely possible. I mean, I don't know. I've read about that, but it's not something I've done research on. And I think may well have been done with good intentions, because if you look at the way people who experience chronic pain conduct their lives, it's very isolating. Pain itself is a big loss to the economy. So if we could find a way of effectively treating it, I think it could have tremendous benefits. And it's one of those areas where, of course, you have to worry about unintended consequences. And it could be that alerting the medical community of the problem had the unintended consequence of treating it in a very counterproductive way. All the way in the back.
My name is Laura Byron. I'm a physician scientist working on addiction. The states have been given the opportunity to apply for $30 million a year for 3 years to fix this system. and not give any treatment, but at a systems level. So if you had your magic wand, where would you attack the system?
You know, $30 million is not that much money.
I know it's not that much money, but...
So the question is, the states have the opportunity to apply for $30 million over 3 years.
No, per year.
Per year, $90 million over 3 years for a system-wide approach. And I guess I would recommend using that money to try to evaluate what works best. So use it for anti-addiction treatment, use it for emergency services, and use it to enforce. I don't know where Missouri is in terms of how many pills can be prescribed at a time.
7 weeks or 7 days.
7 days. And I don't know how the monitoring works. I don't know what violation is like there, but system-wide, it seems to me that that's something that can be looked at. You know, my expertise is in the economics. But I would say that the problem is, if you think about the scale of the problem, and how many people per year in the state are overdosing or requiring medical attention, that's relatively small if you want to try to treat addiction. Yes?
Yes. I wonder, in your cost calculation, if you consider the child abuse, you see that, the parents who get addicted ignore their children, the horrible emotional costs in prison and people that commit crimes to get money to do that. And second of all, you've done a great job explaining it's so horrendous that it seems like only permitting its use in hospitals, that the disadvantage of people suffering more pain because they had to use other non-addictive drugs, it's so obvious they should just be banned unless it's in hospitals under controlled circumstances. I don't understand. What are people thinking? They don't get it. That's what happened with Dexamyl and Dexedrine for dieting. In the 50s, they just banned it. And it's so horrendous. To me, that's obvious. I don't get it. What are people thinking?
So the easy part of your question is the costs that you mentioned are not included. Only as an ancillary matter if they get caught up in the calculation of the cost of life. But you know, the children being born addicted would not be included. The cost of the treatment should be, but for the most part, the $750 billion figure I gave is most likely an underestimate because of some of the costs that you mentioned. I guess, you know, on banning it, which I can see a case for, a big step towards banning it is restricting to a 1 week's prescription at a time. We still have a problem. So even if it was banned, even if was used, even if our usage went to the same level as Canada or the UK, which is considerably lower, we're still going to have the problem of an estimated 2 million people currently being addicted who are going to look for alternatives. And it's the nature of addiction that people need more powerful medication to reach the same level that they were at before. So we're still going to have this as a public health crisis. Yes?
Yes, so looking at your map, your heat map of the knowledge before us and crisis, did you look at the underinvestment in safety net in those areas and whether that's influencing, you know, given the political climate around decreasing that and moving towards?
Right. Right, that's an excellent question. I controlled for some features of the safety net, like unemployment benefits. I wouldn't say that someone who's skeptical would be convinced that I did a great job. And I kind of viewed what I was doing as exploratory. So that's an area, any students are looking for a good senior thesis project, which would be a good area to look at. And with the county level data, you've got, oh, I did do this. I mean, many of those programs are state level. And I could look within states. And when I control for states, just using the county variability within states, you get a pretty similar pattern. Yes?
two other main explanations for lower participation in the labor force include greater automation and also the fact that the middle class has less purchasing power and we need fewer workers to create the consumer products that the middle class will produce. Do you think reversal of the opioid crisis would ameliorate those two impacts at all?
It's a good question. So I kind of think of those two as combined in that demand has dropped for less skilled workers. Could be because of automation. Could be because of international trade. I suspect it's mainly because of automation, as you suggested. And that could cause labor force participation to drop independent of the opioid crisis. And I suspect it has. The labor force participation rate has declined in other countries which have faced similar kinds of problems without the opioid crisis. Not as much as it's dropped in the US. Will a stronger economy reverse labor force participation? I'm very skeptical. It works around the edges. So we have the unemployment rate now at 3.7%. It's the lowest it's been in 50 years. Labor force participation over the last 4 years has been totally flat. If you look at prime working age men, it's up a little bit. That's been offset by the fact that we have an older workforce and people are retiring. And the downward drag because of retirement is going to continue for the next 20 years. The calculations I made when I was chairman of the Council of Economic Advisors was that we're losing about 1/4 percentage point of the labor force participation rate a year because of demographics. Greg Mankiw, when he was chairman for George Bush, came up with the exact same figure, so it's a bipartisan estimate. That's the headwind that we face. There's a limit to how much a strong economy can draw people back. And in fact, if you look at the numbers, it's just fascinating. Labor force participation among prime working age people has increased over the last few years, not because those who left the labor force have come back, but because people are staying in the labor force longer. I think it's very difficult to get people who have rearranged their lives, who have retired early or made a decision that they're going to take care of their children or they're going to move in with their parents or a surviving parent and have stopped looking for a job for a period of time. I think it's very hard for them to come back to the labor force. So I think having a strong economy is really helpful for the U.S. There's no question. There's no question that workers gain when the unemployment rate is low, and we're seeing that now with wage growth. But I don't hold out much hope that there's going to be a wave of people coming back to the labor force, even if the unemployment rate continues to decline. I think we'll be lucky if we stay even going forward.
Let's thank Professor Krueger for an excellent